Hello, good morning. Are you okay? Okay? Everybody is here thinking, oh my gosh, all these codes, everything. Well, it's more difficult than what you think. So just relax and enjoy the fact that we are sort of facing a challenge with brave people, as you are. Because I think that you didn't need ICF to know that you are brave, because you are already working with people who are facing situations in which they need to be brave. So in a sense, I am happy to speak to brave people that are enough brave to work with the fragility of human beings. And I think that this is, in a sense, why we are here. We're trying to find scientific manners to face the fragility of human beings. And I'm really pleased to do this. I thank you for the words, my friend Ivona. And I am actually the chair, together with my colleague and friend from Korea, Ha-Young Lee, of the Functioning Disability Reference Group, the group of the WHO that is taking together those that at the level of collaborating centers are working on ICF. I come from the Neurological Institute, and my clinical background, in a sense, has been helping me to appreciate the value of public health. It's been a long time I've been working on the ICF, 25 years, and I think I've been following throughout all the development and the difficulties and the enthusiasm. It was right. I certainly have enthusiasm because I share enthusiasm in what I do. And this classification has been representing, and it's very young. I mean, it's just an adult. It turned 18 this year. So he's leaving his childhood and he's entering into its adulthood, which is, in a sense, a good thing, but we want a good adult. And I think good adult needs good parents. In Czech Republic, we have some of the good relatives of this classification. And I think that it would be very boring if I only mention about a classification speaking about the codes. Because in fact, this is it. I mean, how can a classification of 1,047 codes, which are divided in domains and body function and structures, activity and participation and environment, become the Trojan horse to speak about the culture of functioning in a country? We have been agreeing with the WHO group and with the different experts that the personal factors are not going to be classified, and it was decided last year in Seoul. But you all know that ICF is the issue of codes, but behind each code there are stories. And every time that you put a code, you are telling a story, even if it's only a letter and a number. That letter and that number represent for each person a story, represent something, represent something that you want to communicate, something that maybe the person has been communicating to you. So these codes are just codes, a letter and a number, but they tell us stories. And this is why ICF is much more than just a list of 1,400 codes. It is something that has been changing the debate about functioning and disability. And it is changing in many, many countries of the world. It is changing it now. We're lucky we are from Europe, and in a sense, Europe was one of the continents of the WHO region that has been first implementing the issue. Maybe because of the culture of rehabilitation, the culture of taking care was already there for many, many years, so it was, in a sense, easier. But we certainly are facing, and it has been already mentioned by them. In fact, I could skip almost all my slides, and you said everything I wanted to say, but I'll repeat. I'll repeat with another voice, so maybe just to make myself clear, I just repeat the things that Justina said, but in a different manner. And I'm just saying that we are facing a change in the disease partner. Also, I started to work with the Czech colleagues in 2004, and since then, I've been following the history of how Czech Republic has been changing in terms of its politics towards disability, its approach to disability, and it was done through the colleagues working in Charles University, but Olga and Ivona and Petra and many, many others that have been sharing my pathway towards this point where we are today. And certainly it is true that we have an increase in this epidemiological transition of chronic diseases defined as non-communicable disease, not passed from person to person. And we know that 1 worker out of 4 has one chronic disease. But we also have this age quake, the aging of population, which is a great success for us as doctors. I mean, I'm so proud that we can say that in our countries, people age. We still have life expectancy up to 55 in some countries of the world. In my country, Italy, women have a life expectancy when they are at their birth of 88 years and men 87. And I think this is an enormous success. But it represents also an issue that we had to take into account, because this is a WHO slide that shows each dot is a country, that shows that after age of 70 or something around there, all people tend to have a decline in functioning. So it is natural of us, it is natural of our body to have this. So the epidemiological transition and this aging process certainly are telling us there are things that should be done, maybe to keep the functioning, and this is why there's this big interest into prevention, into stay active, in telling people empower yourself, because you will age, your body will naturally go towards an aging, and you need to keep your functioning up. And this is something that also provokes a series of definitions. I think you all really appreciated the first slide of Dr. Konstajek showing you, is this a health thing or is it a disability thing? And this goes together with the different definitions that we have around. We speak about people with disability, people with chronic condition, people with non-communicable diseases, old people, aging people, and then we have the children with disability and the workers with disability, and we have those who have the driving license because they have a handicap target and so on. And each of them has a political silos, has a label that is putting them into a box. And this is why there is a big confusion around there, because, I mean, who is going to open its box? I mean, if I open my box, will I give also my power to you? I mean, it's an issue of power and money. And this is the point of, I don't want to open my box. I have the box of non-communicable disease, and these are mine. And I have the budget for that. Why should, I mean, I don't want them to be mixed with the box of disabled. I mean, that's another box. This is under social, while non-communicable is with the health, and usually health is more money. Oh, okay, and I don't want to give the bus ticket free for the non-communicable disease. I want to give them more, but they are patients. They're not disabled. And all this goes around and around in almost all the countries. And I think that this is part of the issue. We don't really think, and also many of these things are related to politics, and usually politicians have the life, I mean, in my country of 6 months, in your country I don't know how many years, 2-3 years, but life of a politician is too short to take long-term decisions to open these boxes. And that is one of the issues here, is not only the issue of terminology, it's the issue of where is the policy beyond each of these definitions. And in this big area, we put this book. It's a book, 1,470 codes. It's a book which is based on a very strong model. The model that is like in a McDonald's hamburger. I mean, have you been to McDonald's? I think all of you have been. And you know that if you have an hamburger and you have the bread up, the bread down, and the meat inside, and if you forget to put the bread down, the meat will follow. And what is the bread down that is so important? It's the environment. If you forget that, the whole hamburger will fall down, and the whole model will fall down. And that is why I think that it will be very important for us to remember who is capturing the codes of environment. Who is coding them? How do we code them? Where do we put them? I mean, they are not part of the model. I mean, we don't want them. I mean, and then they enter prepotently strong. They enter when a state is unable to take care of people and tells the family will do it. Family, environmental factor, facilitator. If you forget to count them, okay, we will not have the clear idea of the functioning of the person, but how, do we code the family? Where do we put it? Well, it has been mentioned that certainly the ICF classification has its role together with the other members of the family. We have the ICD-11 now. Still, many countries do not adopt, and my countries, I have to say shamefully, that we still are with ICD-9 CM, and that is very difficult for us to go in front. I mean, when I was in Canada, there was the meeting with all the countries of the world, and WHO was presenting, and okay, all the countries are with ICD-10, and there was me and my Italian colleagues saying, well, all but us, but we didn't really say in public, but I'm saying now that we don't have ICD-10 yet. But this is what we have, the new classification, a new challenge, a new way, new diseases came in, science is progressing and is putting things. Is science progressing in functioning a disability? Yes, it is. It is because technology is advancing, because we are becoming more able to identify the patterns of diagnosis, and this classification helps us to put things in the right place. They help us to do a picture. When you do a picture, you don't expect the picture to move. You expect the picture to tell you what it is there, what are the details, and it depends how much detail you want this picture. And this classification can be zooming down to one person, but also staying up and give us a picture of the functioning of a population. And we are really looking forward the next classification next year, the ICI, the classification from health intervention. Everything is health intervention, in fact. But in a sense, we are really expecting that these three classifications, through the good things that the informatician will give to us, will help us to count things. Many, many things just pass there as unknown. And once you start thinking, what are the interventions that are put in place? There are many more, and sometimes people don't even recognize them. And it is important that we try to put them through a classification. But let's go back to the ICF. I think that the ICF, it is important for its idea that disability is a continuum. This doesn't mean that all the people that have a problem in functioning that we can classify will need a pension. So it is really also important to define the difference between counting and having the picture and deciding which part of this picture will be subject to my funding, to my intervention. Not all the people that have a problem in functioning that I can capture with a picture will need the same level of assistance. But this is one of the things that is frightening politicians. If I really count all of them, should I give money to all of them? So it's better if I don't count. This is one of the political processes that is behind a lack of precise information on disability in the countries. One of them, but this is certainly true. If I count all of them, does it mean that I have to pay all of them? So if I go back to the slide of Nenad, health or disability, well, health will go in the box, health intervention, so I know where they go. But if I put everything in the disability area, then who is paying for it? Is it going to the health, to the social? And that is why, in a sense, when we say that it is the outcome of the interaction between health condition and environmental factor, this is giving us a relief. Not all the intervention that will create benefits on functioning and will reduce disability in a country are only related to health. In many, many countries, I think I've been traveling in the last 5 years in more than 52 countries of the world to look at disability situation. And I think I have a very good perspective of how is disability around the world. And I believe that the idea of the biopsychosocial model offers some interesting solutions. For example, we already know that the two areas that create major problems at every level in every country are mobility in terms of body function, mobility and cognition. These are the two areas that create the highest number of functioning problems. So mobility could be related to intrinsic mobility. My body, I cannot move because of a health condition, so is my body function with the problem. However, mobility is also related to how many transportation availability I have in the country around me. Then the intervention that will decrease disability at the country level is not only acting with rehabilitation or with the wheelchair on the person, it will also be providing transportation, create accessible transportation to people. And that is not something that is of Ministry of Health. It's a work together of Ministry of Health and Ministry of Transport. And I think when we think how can we reduce disability in a country, The burden is not only on ministries of health or social affairs, it's an issue of a country. So disability, it is the red flag how a country is acting towards the fragility of its citizens. So then ICF becomes a political flag. This is how I intend it. And it has, in a sense, this issue of thinking an environment as something that involves everybody. So there is not one minister alone that has the responsibility of making the disability of a country to go down. It is something that is shared. It is shared between different authorities. It is how do we look at the fragile citizens of our country. And if we say, okay, it is 15% of people who have a disability, well, we have much more of the percentage of population who has some health disorder or disease that is creating some forms of disability that we should think of. And then the intervention should go to decline the level of the country, in a sense. Decline the disability level of the country. So the biosocial profile of functioning is the best indicator of treatment needs and service outcomes. When we go at person level, of course, we don't want this elephant to be taken only for his pieces. We want the full profile. Well, who is giving the full profile? And that is difficult because I can say that, okay, are they doctors? No, doctors they are not. Are they teachers in school? Is the family, is the person? Or is a combination of all of them? And in a sense, when we look at what are the different elements around the person, and this picture has been used by the Belgian government to define its health and welfare policy, what came out is that they were discovering that around the person you have the environment, and if you decline this environment, this will be looking at the family, the association that you have, the private life, and the role of the public sector, and some personal factors that are not classified in ICF, but they are there, and which are the services that are offered. And if you put on a table all the things that are around the person, you will discover there are many, many, many issues that could be tackled from different perspectives that can be also become health strategy. But it is also true that if it is disability is the interaction with the environment, it is also true that there are many barriers in all areas of life by people who have a health problem. And they can be in the area of education, employment, social and political life, community participation and health. All of these together, in fact, create and provoke and make us the need to see several barriers. There can be barriers of inadequate political standards, negative attitudes and discrimination and stigma, lack of provision of services, problem with service delivery, inadequate funding, lack of accessibility, lack of consultation and involvement, lack of data. All of these things cannot be solved at one level. They need, of course, an overview. How do we deal in general, in broad terms, with the health of a population? And I think this could be the role of a Czech WHO Collaborating Center to look at the different things from the different perspective and using the ICF as one of the possible tools to face all of these challenges that are here. Because barriers have negative consequences, which is lower educational achievements, lower levels of employment, higher rates of poverty, and poorer health outcomes. This is true for all countries, wherever I go. I mean, there is not a country that is different from the others. I've been from Asia to Africa, to Latin America, and to Europe, and it is always the same. And it is something that is recurrent, with different levels, of course. But at a certain level, it is the same everywhere. And this is where the needs of ICF, you have seen this slide many, many times, but I think that saying that it is, in a sense, the starting point for an approach to achieve and maintain the level of functioning in individuals and in population is not the solution, but it is a Trojan horse to understand what to do. It's a method. It's a method. So if I have this method in my mind, I can build up many things. I can build the action at person level, at system level, and also at policy level. So the method of the biopsychosocial model can be used at macro, meso, and micro level. And the use of ICF in this sense being the ICF accepted as one of the UN classification, then also with the use of the UN Convention of the Right of People with Disability, helps us to have an instrument and a methodology to think. I always say, at least you start thinking ICF. You have the health condition, you have the problem at body function, body structure, activity and participation, and you also understand what is the role of the environment. So I think that if I have to go into what happened in my country in the past 20 years, 18 years, we started with some, it was enthusiastically taken. I was there and I've said it was a fantastic journey presenting the ICF. It was really great. And we had many, the model, people loved the model. The model was lovely, everybody was taking the model, the bioscience, and this is the effect that the ICF does at country level. People say the model is wonderful. So they say biopsychosocial, we take it. But then say, okay, now could you please code? No. So, I mean, that's the issue. I mean, people love the biopsychosocial model. People think it's a fantastic way to put things in order, but then you say, would you put things in order? And people say, no, why should I? I say, I like the model. I don't say I like to code. And that's the issue that always comes when you use ICF. And in Italy, when we started the process, in the first 8 years, we entered through two areas. One was the labor policy, and we had a national action supported by Ministry of Welfare, and in the certification reform. We started in 2006. And all the professionals who were very interested in school loved it, and everybody thought it was a great thing for our country. We were the first country in the world to have a minister, this was the Minister of Welfare in 2002, that agreed to use ICF for the matching worker employment. And they changed the different schedules that are matching the work that you have, the capacities that you have based on the ICF. This was a government-funded project that involved all the regions of the country, and many people in the matching employment sector were trained to use ICF for matching the worker. But the problem was that there was no disability assessment before done with ICF. So ICF entered after the person has been declared handicapped by different type of certification, and that was complex. And then if I go throughout also my story, I mean, after 2001 and 2002 with the ICF and labor policies, we had the opportunity with my institute to present the MADIA project, which was the first world project that was trying to see the aim to demonstrate the utility and feasibility of ICF model in measuring different types and prevalence of impairments and limitation. And I think Yvonne is going to speak with that more in detail. But we have been collecting also in this republic, in Czech Republic, different types of disease and disorders between different countries. And that became a big work, a big project, and it was the first project of this type. And we produce policy recommendation on the use of ICF, how you should use ICF, how you can use ICF in clinical to collect data, to compare data, to have useful information, to add the functioning information to the diagnostic one. And this policy recommendation were also with other publication, the validation of the HUDAS in patients with chronic diseases that came out after MADIA, as well as the development of capacity and performance scales, trying to understand when you put the qualifiers, what do they mean? That was a great experience. And in those years, after the MADIA, when the MADIA was almost finishing, the ICF CY came out in 2007. ICF, after 6 years of field trial, an enthusiastic work of all the children community of the world, we have been testing ICF CY and piloted in 18 countries before coming to a publication. And the whole children community were with us. And of course, they were saying, well, doctors out of here. Children community say very few doctors and a lot of education, families, social. Children have a different world, and their functioning is not the functioning of the handicap. Their functioning is related to playing, to school, to singing, and to good environmental factors that create a good development of children. And so all that enthusiasm brought us to the ICF-CY, which was, in a sense, a great success, but it was also an issue, because these 220 new codes created a discrepancy between the ICF and the ICF-CY. And that is somehow what we're trying to solve now, coming out next year with the ICF 2020, bringing back the ICF-CY code into an ICF that is a unique ICF for children and youth and for everybody. And then in 2006, while we were also doing MADIE, the UN Convention for the Right of People with Disability came out. That was fantastic. Everybody loved it, and everybody in the world ratified the rights. Of course, there is no politician that would ever deny the right to work of people with disability, but people with disability don't want the right to work, they want a job. The difference between saying you have the right to work or I give you a job is enormous. The first country that ratified the convention was China, and we were all surprised. And in fact, then at the end, it came out that signing and ratifying a convention is easy, but operationalizing the rights that are in the convention is very, very difficult. And that is the challenge that ICF can monitor. Do you operationalize the right to work? Do people work? And that is the question that you can do through ICF. Are you prevented to work because you are a person with disability? You have the right to work, but nobody is offering you a job. And that is how ICF enters into this debate with the UN Convention. And when we did the systematic literature review with my collaborators, and in the first years, we wanted to see where is it used and how it is used. And only in the first 8 years, we found that we were having more than 600 papers, and we thought it's already a lot. But it is nothing compared to the more 4,000 papers that we have now that have been coming out on ICF. But in the first 8 years, 34 countries were trying to use ICF, and the ICF, in fact, at the beginning of its life, it was only a child, 8-year-old, still a child. It was used in clinical rehabilitation and other contexts, and many were thinking ICF, but it was more at bottom-up approach than a top-down. While ICD is usually taken by governments and sold at the country level, the ICF had an immediate feedback from the countries, from the people, from the users, and very little at the level of governments. And so that was a discrepancy in the uses of ICF that we were finding. But certainly, one of the areas that is taking more and more attention, and nowadays, and it has been already mentioned by Neda, is the assessment of population health. And this is where ICF, in a sense, can find one of its main applications, because it's the base for decision making. Do I improve transportation, or do I increase the rehabilitation centers? Do I work more on the cognitive area, because in my country the cognitive area is the most important thing, or do I do other prevention areas that are sort of diminishing the disability in my country? So this elephant comes again and again in all our presentation, and we keep moving this elephant from one country to the other. However, nobody has still really done the real picture of this elephant. We still are trying to. We are hoping that we will come to a real picture of this elephant, so that we have a comprehensive approach to describe functioning, going beyond the impairment. It is also difficult. In our medical school, we are trained to identify what it is missing. As a neurologist, I'm not trained to look at what's functioning. I'm trained to understand all the signs and symptoms that are qualifying a disease to have a proper diagnosis. And I am used and trained for 6 and 10 years to identify what it is missing, what it is the impairment. And then you're asking me here to identify what it is functioning. What are the capacities? What are the residual capacities? This is usually done mostly in rehabilitation, but most of the other medical disciplines are not used to identify this. So we also have a problem, as it was mentioned in our training in the medical schools, that the capacities, residual capacity, the intrinsic capacity of the person, usually are sort of getting a bit lost. So there is a growing recognition that disability should be based on the full contextualized experience of health. And we have this instrument, it has been mentioned several times, the HUDAS 2.0, which is replacing the old HUDAS, and it was replaced in 2014, is free, available. And I think it's a good excuse to introduce in a more systematic manner. If ICF is too difficult, however, you cannot say that HUDAS is difficult. And HUDAS is the easiest way you have to measure disability and functioning and to evaluate this biopsychosocial approach. HUDAS, in fact, supersedes the old HUDAS 2, and it is now the instrument that is covering 6 domains of functioning: cognition, mobility, self-care, getting along, life activities, and participation, with a full ICF-based approach. And this instrument is not difficult. This instrument requires only some study, and when a systematic review was done, who is using it, in 2017, Federici and colleagues found that 810 studies from 94 countries published between 1999 and 2015 something on HUDAS. And HUDAS now is translated in 47 languages, and maybe from 2 years ago it has been translated in even more. And it is used in 27 areas of research, of which 40% in psychiatry. And since 2017, psychiatry is going to increase the use of HUDAS, because in DSM-5, that is the classification of mental disorders from the American Psychiatric Association, they said that if you want to get reimbursement or if you want to get facilities for a psychiatric patient, you have to have the HUDAS scoring at the end of the evaluation. So of course the HUDAS use is now increasing a lot, and there's a lot of interest because ICF is not used in the US at all. So they are introducing HUDAS, which is also another Trojan horse to speak about functioning for people. And of course, HUDAS has been translated also in Czech Republic, and you have a tutorial which was done by Olga Zveskova, and you have it in Czech, and it is training Czech people on the use of HUDAS, and it is available, and it's very well done, and you can access it very easily, and it's free. But the disability assessment, which could also be done through the HUDAS, it's certainly a gate, but it is also one of the social entry points for a broader use of functioning. And I think that it is a gate that opens door to benefits, services, supports, all the things that in ICF we identify as facilitators. So the disability assessment and the disability determination needs to be clarified, but we'll say that once you've been certified in the process, the disability eligibility is which kind of benefits or supports you have rights to. So if you can simplify, you have to have the disability assessment, and then a determination, that is the decision, and then the eligibility, so the possibility of multiple criteria. And then around this, you need to have the laws that define that you have a certain procedure or another, and the environmental factors that can give you the benefits you might need. So these needs that can be responded to could include social security, disability pension, health and rehabilitation services, general social benefits, such as income support. Usually, in many countries, the first thing that they do is the free transportation ticket. So they might not provide pension, but they give a bus ticket free for all the people with disability certification, but also employment benefit or also other things. And there is a recognition that the disability assessment should be based on the leave. The 3 assessment, I'm not going into that, but I'm saying that in Czech Republic, you mostly use the impairment approach with some addition of the functional limitation approach. And the idea is that you have to move from the impairment and functional approach to the disability approach. That includes the environmental factors. I'm just running to the end. Saying that I'm doing an international benchmarking of ICF-based disability eligibility assessment, and as of now, we have 15 countries that have, in different levels, some of them have been shown to you by Leonardi. All the countries have ratified the UN Convention. All of these 15 countries, they have a legislation concerning the use of ICF in disability eligibility. Italy and Switzerland have ICF in the disability eligibility of children for education. Germany has introduced, and Liane Simmons will tell you more this afternoon. Australia has been working a lot on disability eligibility. And France, Taiwan, Senegal, Cyprus, and Argentina, they were mentioned by Nena, they have embedded the full disability eligibility scheme in their national procedures. And then we have Russia, Romania, New Zealand, and Kyrgyzstan that are starting the process, but still are not into a full national ICF-based assessment scheme. And in Italy, we are in these days, in fact, in the application of the ICF for the eligibility of children with special needs in the education system. We have an inclusion system, and we're using it. It's an Italian law, which has been voted last year by the Parliament, and through this law, we are starting now a new process of disability eligibility in children. Of course, there are obstacles to transition to an ICF approach. The first is the fear to have perceived the real cost of transition. The other is that maybe ICF will bias towards fewer or more successful beneficiaries, and this is also a problem with the NGOs. That is why you need to involve all the stakeholders in the process. Then, for the low and middle income countries, there might be a problem to this. And also, in some countries, you already have a system that is completely in place. But there are some advantages also. ICF is an optimal reporting structure, so it provides what to measure, how to measure, and it's an international standard, and it's relevant to the convention. There can be different scenarios, choose one, but the different scenarios is that usually you do the medical assessment. Some countries do medical assessment and functional assessment, and others do medical, functional, and need assessment. And at the end, you define that this person is disabled, and you give whatever, a card or benefits or something. And that could be under the form of financial assistance, access to services, or others. And I think that this model of how disability eligibility is done could also be used as how do I want to do? What do I want to do in my country? Of course, the best would be the 4 boxes, the medical assessment, the functional assessment, the need assessment, and the social assessment that brings to determination. But choose it. In any case, the use of ICF brings into a country the culture of functioning. So the culture that says nobody should be left behind, with the common aim of that participation in all sectors is what we want. And this is why, together with Olga, we have been thinking a project that was our next step after the implementation of ICF through MADIE, which was evaluating, is it worthwhile doing? And then we discovered that really it is, and the employment sector, together with school, is one of the 2 sectors where you really can use an approach that is based on ICF that could provide benefits. So we did the Pathways project that is related from 2015 to 2018. It was related to look at how you can use a different way to tackle the world of chronic disease into the employment sector. And we have been mapping the European welfare models, and for Czech Republic, the Charles University has been mapping all the things that are going on in Czech Republic. And in 2016, Czech Republic produced a law that is embedding ICF in the labor sector, and it was reported in this report, as well as there was an interview that was done by Petra, I think, together with Olga, to different politicians, different stakeholders, the head of industry in Czech Republic. One of the questions is unemployment of people with chronic disease high in national agendas? And the answer was no. Many politicians, although you have a law in Czech Republic, they are not aware that there is the issue that 1 worker out of 4 has low back pain, is suffering from diabetes, is suffering from rheumatoid and musculoskeletal disorders, and all of this impact on employment, and people don't have an idea. And this is where the issue of having a model that is taking into account not the box, but the functioning would be very, very useful. We produced in March 2018, and this was our last publication together with Olga, a policy guidelines for effective inclusion and integration of people with chronic disease in the workplace. It was national and European perspective, and for the Czech Republic, and I think I want to underline what it is in red, because the first paragraph in red was written by Olga Zveskova, which says one of the recommendations was that appropriate support to employers' needs should be accompanied with intervention for awareness raising, as well as services for managing the long-term sick leaves and the return to work. Respectively, the financial benefits to persons with chronic disease should be used as an incentive for participating in the workforce, rather than a compensation for those remaining inactive. That was her fixed point. If I can speak now, closing, remembering Olva, I would say that she was so active, that she was always bringing new ideas. She was so young, despite she was not that young, because we all age, and luckily we age alive, and luckily when we age we have ideas. And her ideas were that all the traumatic brain injury people that she has been encountering and treating in all her life, they have to go back to work. They don't need to stay at home with a pension. They want to be active in life, they want to participate, and this sentence I put in it because we wrote with her and her group, which was very important for us because it gave us the pathway to the present project that I'm coordinating, which is a project called CRODIS, that is the follow-up of pathways, and it is in 22 countries of Europe. I'm coordinating the issue of having people with chronic disease to stay at work, to go back to work. And number one issue here is cancer. Many people with cancer in our countries, with the new therapies that we have, they want to go back to work, but most of them are put in the box disabled, and many of them are left out of the workplace. While, for example, the cancer of the breast therapy, until 5 years ago, it was 6 months intensive therapy during which people were staying at home. Now the oncological treatment of cancer has completely changed. You do 1 week per month, and the remaining 3 weeks you want to go back to work, but legislation in the countries are not prepared for this. And so we are creating boxes of people with disability, while these would be people that could work, could go back to work by adjusting reasonable accommodation. So I would say that, in a sense, there is a roadmap for social justice also that is bringing in by ICF. It's not only something that is related to classifying. I really understand the issue of putting it into a classification mode, but think as a roadmap for justice. I mean, the fact that ICF is a model that is, in a sense, the good model to develop social justice in a country, because it characterizes disability both in terms of the biomedical experience, but also the social. So it clarifies where are the different things in the pictures. And also the descriptive analysis of the situation of the person, the knowing of the situation, has an implicit normative value. Knowing that the person age 65, for example, in the UK, if you have a stroke after age 65, you are denied rehabilitation in the hospital, you are sent back home. Or knowing that a girl that is with disability in some countries is not even considered a person, or denying a job, a person that is recovering from a traumatic brain injury. Knowing these things is not only describing a thing, it is highlighting the lack of respect of human rights, and thus brings ICF in an instrument that is helping us to require for justice. Justice that has to respond to the last question of my talk, which is how much disability. In fact, all of this brings us to consider the role of environment, political, economical, social, in another perspective. How much disability countries choose to keep. If you know the thing, you cannot deny them. It's better not to know anything. So you cannot say that you're not doing anything. But if you know things and you don't do anything, then it is not a destiny, the disability in your country. It's a choice, because you're not doing things to change the environmental factor that can reduce it. And so I will say that, and I'm sure that Olga would say this, because she would never look at the past. The challenge of the unknown future is so much more exciting than the stories of the past.